Welcome to Connecticut eHealth podcast, educating, conversing, and connecting for better health. The Connecticut eHealth podcast is a space where we get together with local and national experts, key stakeholders, and other individuals in the space of eHealth to discuss health information in Connecticut and around the country. This podcast is brought to you from the UConn Health Interoperability, Innovation, and Learning Lab, where our mission is to promote the optimal adoption and use of eHealth by providing education and engaging in conversation with leaders to create connections for better health. So let's sit back and get connected. Hello, I'm Tom Agresta. I'm a family physician and medical informaticist at the University of Connecticut, and I'll be your host for this episode of the Connecticut eHealth podcast. Today's guest is Vicki Veltri, Executive Director of the Connecticut Office of Health Strategy. She first served as the head of the agency in February 2018, and then Governor Ned Lamont reappointed her in 2019 to oversee the office's mission to implement comprehensive, data-driven strategies that promote equal access to high-quality healthcare, control cost, and ensure better health for the people of Connecticut. So welcome to our podcast, Vicki. We're glad to have you.
Thank you, Tom. It's great to be with you.
So, Vicki, why don't you tell us a little bit about yourself and your role as the Executive Director for Connecticut Office of Health Strategy and how you came to that path?
Well, thanks so much for the question. And it's great to be on this podcast. I know you've been doing a great job with these podcasts. We think it serves an important function. So as the Executive Director of the Office of Health Strategy, my job is to essentially oversee the office's mission that you pretty much just laid out. So it's great that you listed what our mission is. I come to this role from a previous role as a policy advisor for the Lieutenant Governor and from the Office of the Healthcare Advocate, where I was a healthcare advocate for 5.5 years. And the role really brings together several functions that existed separately in state government that we think make more sense together. And they include innovation work. There's a lot of work going on in healthcare innovation, whether it's value-based payment or community health initiatives, primary care, resourcing, our executive order, which I can explain a little bit more about if people want to know, and technology, statewide coordination of health information technology initiatives, and health systems planning, which is a huge function in the state. So the role is to essentially oversee that. I have 3 great teams. We have a great overall team at OHS, and we tend to work with partners outside of our office, including you and other folks, to help us achieve that mission, which is a necessary function of the Office of Health Strategy. It doesn't function in a silo. It is a necessary part of our role to work with other agencies and stakeholders outside of our office.
So, Vicki, I've certainly seen and experienced the collaborative approach that your office at OHS has in trying to improve the healthcare delivery system in Connecticut. Can you walk through a little bit of the 3 main areas and talk a little bit about what the OHS is doing in those areas? Sure.
So there are 3 main areas, although they overlap a little bit, which makes a ton of sense and also supports the rationale for having the office together. But there's an innovation work stream, and the innovation work stream comes out of some previous work that OHS had been doing in regard to a large grant that we had gotten from the federal government called the State Innovation Model Initiative. That grant was an attempt to try to ask states to bring people together to try to drive multi-payer healthcare delivery reforms. In other words, let's bring our commercial payers, our state payers, which include the comptroller, Medicaid, et cetera, around a table, along with partners outside of our state agencies, to drive healthcare delivery and payment changes to improve the way we deliver healthcare and the way we pay for healthcare to support that delivery. So that innovation work stream still sits in our office in a team that's headed by Kelly Cinco at OHS. And its work has centered around taking on some of the work that had happened before from the state innovation model, including trying to drive changes in the way we deliver and pay for healthcare, specifically right now focusing on primary care, which we think really needs better resourcing
I can agree
in the
there.
state of Connecticut and across the United States, quite frankly. I think primary care has been under-resourced, and that became kind of obvious in the COVID pandemic and has become obvious with some data we've run that primary care is really not resourced as well as the rest of care in the state. And we think that better resourcing primary care and offering new delivery models and ways to pay for that, those delivery models will allow us to better resource it into the future, attract a workforce, which has been dwindling, and respect the kind of ongoing changes that are going on in the ether, where primary care isn't always delivered the way it used to be delivered. So that work stream is focusing on better primary care resourcing. It's focusing on controlling the rate of spending growth on healthcare in the state of Connecticut via Executive Order number 5, which the governor signed in January of 2020. The idea there is that, like a few other states and states that have now followed us, we are setting cost growth benchmarks. And by that, we mean per capita spending growth benchmarks. And the idea is to get a better eye on what we are spending overall on healthcare and try to restrain the growth of healthcare spending to a more rational rate of growth that reflects growth in the economy in Connecticut and median income growth in the state, which has been lagging some of the other states. So as spending continues to grow at a rate that outpaces economic growth and income growth, it's becoming more and more unaffordable for people in the state of Connecticut. So we're working very hard on those cost growth benchmarks, putting out data on how we're doing on spending as a state, what areas are driving those costs, and how we can work together collaboratively, again, across the ether to bring down that spending growth. So primary care is a huge focus of that. And we set a primary care spending target under that executive order to try to get people focused on better resourcing primary care, to increase the share of spending overall on healthcare for primary care to what it is now, which is around 5%, to 10%, to double that spending in a way that makes sense. So the target is out there as an umbrella, and it is not the end in and of itself, but a way to get people moving towards resourcing primary care better. And then the other piece in that unit is we are working on quality benchmarks as well. So bringing healthcare spending growth under control is good, but it's not good if quality is going to suffer. And if equity concerns, which have been around for a long time in Connecticut, get worse, they need to get better. So we are establishing quality benchmarks beginning next year. And that team is also working on some community health strategies, partnering with the hospitals and others on our health enhancement communities, which is an initiative which brings together 9 regional collaboratives around addressing upstream issues that affect overall healthcare spending, but also well-being in the state. So there's a lot of work going on in that unit. And then we have I'll go to the Health Systems Planning Unit quickly. That unit is the former Office of Healthcare Access. Most people would know it as OCA previously, but is now HISP, as we call it, the Health Systems Planning Unit, because of course everything has an acronym that you must pronounce. But the HISP unit does many things. Certificate of Need is probably the thing it's most known for when there are mergers and acquisitions of certain types or new facilities being established of certain types. People have to come and get a certificate of need. So they have to undergo a regulatory process at our office for that. In addition to that, the unit is also responsible for a statewide healthcare facilities and utilization services plan that's put out biennially. Tells you the pattern of service use across the state and where facilities are. It also is responsible for collecting financial reporting from our hospitals. So quite a bit of data in the Health Systems Planning Unit. And then we have the Health Information Technology team, which has administrative oversight, or OHS does, of the HIE, but also goes beyond the HIE into the all payer claims database, which is a very large database with millions of entries of claims data that we collect from all the payers in the state and Medicaid, so we can better understand what's driving costs, where a service is used and why and how much, what are the variations across the state. And that team will be working now on a couple other items, which include Public Act 2135, which is the collection of race, ethnicity, and language data by state agencies and by providers participating in the HIE. And also as a team, now that we have a new HITO, Health Information Technology Officer, Sumit Sajnani, in our office, he's going to be working on bringing those data sets together that we have in our office to plumb them more and use them more than we're actually even using them right now, which is quite a bit. So a lot going on in the office.
You certainly do have a lot going on, and I've had the ability to and the pleasure actually of being able to collaborate with you on a number of those things, and one of which is our collective, longstanding desire to see an active health information exchange in Connecticut, and this last year, Vicki, you have a good reason to celebrate because we now have 7 months of our state HIE Connie being launched. I know that you have been at this as long as I have, the last 10 or 11 years trying to get that launched. So what do you see for Connie's ability to help OHS meet some of its mission? How do you envision that happening?
So that's a great question. I want to say first that you're right. We've been at it a long time, and I couldn't be more thrilled that we stood it up and it's up and running. And very proud of all the efforts of everybody who participated in making that happen, which include you, Tom, and lots and lots of stakeholders to get it up running. And it's under the direction of Jen Searles, who's a fantastic executive director. So I actually couldn't be happier also with the leadership of the HIE as it moves forward. And one of the HIE's purposes, in addition to some of the obvious things that people think of HIEs for, which, care coordination, ensuring transfer of records when they need to be transferred in real time, or seeing a patient's experience in real time, or useful tools like imaging transfers. And so you don't have to have repeated imaging tests and things like that. In addition to those, the HIE by statute, by the way, has to serve the purpose of helping fulfill OHS's mission. And I see it doing it in multiple ways going forward. In fact, we're in preliminary conversations now with the HIE around how it can support the work on the quality benchmarks that we're setting for the state. So as I said before, Executive Order number 5 includes quality benchmarks. We are looking towards measuring quality, not just as screenings. The number, did you get your well visit? Did you have your diabetes screen? But also, what are the values? What is the A1C level? What is your high blood pressure actually looking like? As there's much more of a movement, and there continues to be a movement towards measuring quality at a clinical level, not just a screening level. The HIE can be a useful tool for us in sort of aggregating that kind of information by, let's say, provider entity, a large provider entity, for purposes of that measurement at a state level. I also see the HIE useful for that for payers and providers as they go forward and enter contracts potentially that are value-based payment type contracts, where quality is one of the key components there. And those quality measures that are in their contracts are becoming more and more clinically oriented. And the HIE has that data. One of the other things I think is really important is provider directory, or provider, we see providers, the landscape has changed dramatically and is changing dramatically over the last few years in terms of vertical acquisitions and other acquisitions in the healthcare space. Providers are moving from location to location, maybe even faster than the, let's say, DPH licensure tracks them as. So it'd be great if we could see real-time tracking of what networks look like and where they're situated and which providers are participating in those networks. And I think that the HIE has other tremendous capabilities. So for instance, while we host the APCD, it would be great to pair, what we're seeing on the APCD with clinical outcomes, and how are we seeing performance in the landscape on clinical outcomes tied with the claims that we're seeing. Like, are we seeing reduced claims in a certain area, increased claims? And I do think the HIE has the potential, now that there is a requirement in state law that providers participating in the HIE collect these REL data, the race, ethnicity, and language data. And I would love us to go down the SOGI path as well, sexual orientation, gender identity path, that having that data available at a patient level and then being able to aggregate that and see how we are performing as a state on overall quality via the HIE, and potentially through public health tools, reporting tools, is the sky's the limit in terms of what we can see there, and also how we can then address what we're seeing. Because I think we all know that we have tremendous disparities in the state, but gathering that data is critical.
Definitely the first part of that's required in order to kind of make positive change is to measure where you're at, right?
Right, exactly.
And truly understand that. Yeah.
Yeah, you can't improve what you don't measure. We say it all the time, but it's true.
Yeah.
We have tremendous disparities in the state. We know that from some public health high level reporting, but to have it at a deeper level would be even better. So we would know, we could know not only at the state level, but how we're doing at a sort of advanced network level, how we're doing by race, ethnicity, but also language and other areas. So we could really target improvement.
Yeah, that's a wonderful vision. And I think that we're on a path towards getting there. Vicki, can you speak a little bit about OHS's role in sort of the governance of the HIE and around state laws and policies, and how they play out with data access and things like that? I know there's a large group of individuals who really pay attention to that and want to be sure that we're doing things the safest and most appropriate ways.
Right. So in terms of governance, so Connie is a nonprofit, and it's governed by a board of directors on which the HITO sits. So the HITO is the chair of the board. So in day-to-day management of the HIE is obviously in the control of the board of directors. That said, OHS has a role of administrative oversight, which is not as clear a term as you might think, based on the fact that there is a discrete board of directors. However, that said, Connie, must comply with state laws when it comes to access to certain data, right, and patients' rights. So, for instance, there are restrictions in terms of sharing certain kinds of data without affirmative consent from a patient. So, to my mind, immediately comes to my mind is HIV status, because that's been a long-standing one. So the OHS convened some consumer groups, and we worked with our Health Information Technology Advisory Council, as you know, which is also a statewide body that advises OHS and the HITO on policies, and had a much more active role in Connie formation before Connie got started.
Right.
But nonetheless, through that process, there were multiple group meetings and design groups and outreaches about how we should operationalize access to data and patient rights. And there was a consensus view. There was a long process undertaken to determine how we should go forward with respect to patients' rights to data, access to data. Obviously, the statute that governs the HIE is all about patient access to their own records, right? And to be able to see their records, get access to them, have a patient portal, right? So patients don't have to go to 5, 6 different portals, which we think is, which I feel is really important. As a consumer of healthcare data myself, I would like the ability to go to one place to see my information. But then there's, how do I share my data and who should I share it with? So the long process was undertaken advocates at the table. There were consumer focus groups done about how what should be the process for the HIE. Should it be an opt-in exchange? Should it be an opt-out exchange? And the consensus, though not unanimous, but consensus, I think, was that we be an opt-out exchange, meaning your data is in unless you opt out. So meaning, and you can opt out from sharing all your data, some of your data. And so there's an educational process that has started to be done, and I think needs to be done robustly. And we've been having conversations about that to ensure that people understand they do have the right to opt out of sharing their data and could opt out for certain kinds of data sharing. So they may elect to be in there completely, or they may elect to have most of their data in there, but not a certain kind. And they need to take an active step to do that. Our data, we don't control day-to-day access to data. OHS, as I said, we have an oversight role in the sense that we are on the board and chair the board of directors. But the process of governing the daily use of the data and who gets access when rests not only in state law and federal law, but obviously with the board. There's I don't think, any support for just, willy-nilly sharing patient data. There has to be a purpose, and there has to be a purpose consistent with federal law. So some of the things we've been considering are consistent with HIPAA. They have to be consistent with HIPAA. And we must abide by HIPAA, which is the federal law controlling access to information. So we have a role. I guess I took a long time to explain that. We have somewhat of a role in it, but probably not a complete role because we're governed by state and federal law. Right. So we have to follow those laws when it comes to accessing data.
Right. That's a good explanation, Vicki. We're going to take a brief moment now for talk about our sponsor support. We want to take this opportunity to thank Connie, Connecticut's official health information exchange. Connie was established in 2019 to oversee and provide services to support the exchange of health data in the state of Connecticut. Connie is an independent and not-for-profit organization. To learn more about Connie, please visit conniect.org or go to the show notes from today's episode. Vicki, as we return to the conversation, I know that Connecticut has experienced some challenges thus far in implementing its health information exchange. What kinds of challenges have we overcome, and what do you see the potential risks for Connecticut in the future?
So, yeah, as you and I know pretty well, Tom, because we were all we have been at it a long time. I think we've overcome some of the challenges in terms of setting up our own structure, let's say. I think back in the day, we were looking at, we need to set up our own exchange. Everybody needs to come to us. We have to have one place, everybody to go. I think we have learned that actually through the previous failures, and sometimes there's a good reason to come in late because maybe you do learn a few things, that because entities around us got started setting up systems, that it made sense to not structure our own HIE from the ground up, let's say, and start one location where everybody must share their records only and not be able to share it otherwise. So we learned a lot of lessons in there by setting up this sort of federated model where people share information with us. The data, they have data in their own places. There are EHR platforms already set up across the state. And why rebuild that? Let's just make sure we're asking people to share the information they must share with us. So we learned a lot of lessons that way. I think we also learned that, the federal government had set up and incentivized states to set up these HIEs. Many of them had failed because they are these standalone type entities that are creatures, one-stop shop for everything. We learned a lot from that and the experiences of other states around us about how it can't just be an HIE that just sits in one place. It has to create value for people. And if it doesn't create value, it's not going to succeed. So that means it can't just sit there and take data. It has to take the data and do something with it, or provide some value back to the customers of that HIE, which include the providers, right? And the patients whose records are in there.
Right.
So I think funding was also a challenge for us, right? We had one federal funding stream called High Tech, which has expired, actually. So we could not have relied on that funding for the long run. So we had to come up with value-oriented structure, something that we knew could create value for the future to sustain our funding, and make sure also that DSS, which runs the Medicaid program, was working hand in glove with us on moving this forward, because a significant portion of the funding for HIE supports the Medicaid program.
Right.
So that collaboration was absolutely key. And I feel like we have done a really good job with that we're sitting side by side, moving forward on the HIE. So those are just some of the differences I think that we had from before.
Yeah, it actually is quite a journey to see the difference in how it's structured and how it's funded. And I think your comment about value is really the way that things get sustained. So could you
That's right.
speak briefly about what you see the major value use cases, would be for Connecticut's citizens?
Well, some of them, it's funny because some of them we talked about a couple years ago when the Health Information Technology Advisory Council, this is before County launched. Lots of stakeholders got together and sort of said, these are the kinds of things we think need to happen to create value. And those kinds of use cases included imaging. That's one high priority for imaging use cases, right? So,
Yep.
And that's because everybody knows that, imaging is a potential area where there could be overutilization. I go to provider A, I've had my MRI, I go to provider B, I can't get the image out of provider A. And that creates a real problem or they can't share it on the disk, or they can't do something for me to bring it to provider B. Now, suddenly I'm getting another MRI at provider B. Now, that's not very efficient. It's not very good. And it increases healthcare costs and creates problems for patients and providers. So let's be more efficient there in creating use cases. Telehealth and e-consults.
Mm-hmm.
I could see, those are huge use cases for the HIE. In the area of e-consults, just the ability for providers, and you think of primary care, we just talked about that before with the shortage that we have, the ability of primary care providers to share information with specialists through the HIE, to get advice, all these kinds of things, and support that through the HIE is critical. The patient portal is another obviously huge use case. There's also, I think, tremendous value in this quality, the sharing of quality data from the HIE in terms of the readings.
Yeah.
That's the lay person's way of saying it, but in terms of the values of the measures of your healthcare, like your high blood pressure readings, your diabetes reading.
Right. So that's one of the areas that I know that our state comptroller's office is very interested in as well, because they pay for a large percent of the
that's right
costs of care for health state employees, et cetera. And I know they want to purchase value. That's something they really want to enable and facilitate.
Yes, so I think there's value to multiple parties. The trick is the value has to be done consistent with the law, right? So it has to be done in a way that respects federal and state laws that govern HIE activities or data sharing. So that includes HIPAA and that includes other state laws. But I see tremendous value in terms of the relationships going forward with payers, in terms of, for instance, Medicaid wanting to know how its providers are performing, right, on quality data for its patients, for the patient or the beneficiaries of Medicaid. The same holds true for commercial payers. So that kind of aggregated data, I think, is very helpful in moving the state forward as well. So there's a double bonus. It sustains the HIE, but it also improves healthcare delivery in the state of Connecticut. So plenty of use cases, I think, that we could spin out, multiple ones. How about our best
Right.
possible medication history?
Yeah,
That's a
absolutely.
huge one. When you think of, and I had this situation laid out there personally, a family member having multiple meds from multiple providers. Some have expired, some are still, some exist, or some are still active. And some have, maybe they're contraindicated between providers. I don't know, but the HIE serves as a potential source to help reconcile that medication history and get us to one true medication history that can be shared between providers over
Yeah.
and updated and updated.
Yeah, that's
So,
that's my that's my recurring nightmare, Vicky, when the patients walk in with a large brown paper bag that bursts on my table with all the meds,
exactly.
some
Or
of
they
which
have
are,
a list, they have their own list that may or may not be updated.
yes.
My provider didn't have my updated list last week when I went. So there you go.
Yeah,
There's a use case.
we just had a conversation with Neil Sakar, who's our neighboring Rhode Island CEO for their HIE, and they have that as their priority number one use case for this upcoming year, and they want to
Oh, I
collaborate
actually
with.
think it's critical. It's critical. So many people have multiple medications from multiple providers that are not reconciled, and who knows? You're getting your next prescription based on the data the person has in their records, which may not be the most updated information. That is not good either. So, and that's, to me, there's cost associated with all of that, but that's the least concern for me on that one. That is a healthcare, good health
Safety.
use case and a safety use case. Exactly. So,
And talking a little bit about other state agencies, I know that you work hand in glove with DSS, but also with the Department of Public Health.
yes.
And thinking a little bit about the public health use cases for both the APCD and the HIE. You want to speak briefly about that and what you see the future holds for those opportunities.
Thank you for bringing up DPH, because we work with them every day. The new commissioner, Commissioner Giuttani, is fantastic. She'd probably be worth talking to at some point, but we've had a lot of discussions about HIE support for public health reporting tools and things like that to make providers' lives easier and patient lives easier, but also just marrying data sets. So even in the last couple of weeks, we've been talking about what the APCD can illuminate in terms of what services have been received alongside what we're seeing in hospital reporting in terms of discharges and utilization, and bringing those two data sets together. In fact, there's a lot of work going on across agencies to try to bring these data together to mine them better and to make better decisions in terms of policy making to bear on these data sets. So I could see lots of uses related to COVID. In fact, we've been able to, obviously track testing cases and vaccinations through the claims that are in the APCD, and where people are getting services geographically. How much they're paying is always another component, but where are they getting them? Where are we missing populations? All those kinds of things. So we are in pretty much weekly discussions with DPH on how to partner moving forward. And it's not just DPH, obviously the comptroller's office, as you said. We are starting detailed conversations with our other human services agencies about data sets that can be shared and how Connie can support some of the state agencies' work in terms of where people are they getting services, where are they getting services, where are there gaps in services. All of those kinds of things are being brought together in a much more meaningful, I think, and deliberate way as we move forward. So I see Connie tremendous value to state agencies moving forward.
Well, Vicky, you've got a lot of optimism, and I must say you've really made me very hopeful about the future as well.
Gotta be optimistic.
And it's a good time to be optimistic, because I
That's
think
right.
there's a lot of difference between where we are now versus where we were a few years ago. So
We're in a much different place now.
Yeah, as we close up this podcast, can you talk about the next 2 years? And if you had like your vision of the next 2 years for what will happen both through your office and through the office of Connie, what would be the major milestones that you'd like to see, and what kind of value would you like to see in the next 2 years?
Well, I would like to see every provider signed up. That would be great. We have a significant volume of providers already signed up. I'd like to see Connie be able to sustain, self-sustain.
Uh-huh.
2 years is kind of a short ramp up for that, but moving
And
towards self-sustaining itself.
and you're talking
Uh,
about financial
yeah,
self-sustaining, just so
yeah.
folks that
I'm talking
listening
about financial,
understand.
yeah, self-sustained financial model for the future. Though the state will always have a role there because we run the Medicaid program, right? And we also
Mhm.
run the state employee plan. So there's potential, funding streams from those sources. But notwithstanding that, I'd like to see it move in that direction. I think that having lots of the large providers on board in a couple years will make Connie, which already has a lot of large providers, spitting out those use cases and showing, exemplifying how they've worked among the providers that are signed up will lead to additional providers signing up. I'd love for Connie to be in a position where it can also help with a community data exchange. So help our community organizations who also see patients, not necessarily at the same rate as like our hospital system partners, but have those kinds of organizations be able to access data they need to help patients and from the community health perspective so that we're fostering more community and clinical integration moving forward. Because I think that's one of the ways we're going to tackle some of the deeper health disparities we have in the state. I'd like Connie in a couple of years to be able to demonstrate how the collection of that REL data,
Uh-huh.
along with state agencies, has been able to drive some policy changes and or specific improvements in healthcare delivery. And I'd love to see Connie in a couple of years be exchanging or helping carriers, helping providers, helping patients in the value space in terms of providing that clinical quality data and being a resource of that. And finally, having a hand in glove relationship on public health reporting so that Connie evolves into somewhat of a utility for the state, which I think it can be.
Yeah, I
So,
agree with you. I
yeah,
agree with you. I
I
definitely think that would be a wonderful place for it to be.
yeah. I mean, and those are ongoing conversations, but I think Connie has the potential to provide significant utility to the state while also not being government run, which I think is something to go back to from the beginning. And I think the trust level is more with a neutral partner than possibly with a state agency collecting data all the time. So I think Connie can provide that value in a trusted way and sort of a neutral way to be seen as a trusted source for the state to rely on in making policy decisions moving forward. So
I'll go
I think
back
there's
to
only
the
upward potential, in my opinion. But
That's wonderful. So I'll go back to one of the first things that I think came out of the high tech around NHIE, and that was that the patient should be the North Star.
that's right.
And I think all the things you described there actually permit us to have the patient be the North Star, because they permit us to care for patients in a much more cohesive, logical way at the individual level, and it's also at the population level.
Right. And I think that's going to take the patient definitely is the North Star in this equation. And Connie can grow, in my opinion, to support that vision of the patient being the North Star by demonstrating the value now with providers, by bringing other providers on, because not every patient sees, we have smaller providers, right, who are hesitant to participate or don't have resources, don't have all those kinds of things that they need to participate. But to complete the fuller picture of healthcare in the state, to support that North Star view for the patient, we're going to need those providers on board. And to get them on board, we've got to show what we can do, what we're capable of doing. for
Well, I think
patients.
your role at OHS and the vision you have for OHS will also help with that as you kind of make primary care more sustainable as well. I think that part of that will be bringing primary care clinicians, small ones, into Connie and
That's
utilizing that as a
absolutely the
resource.
case. So you're on to me, Tom. You're on to me. So yes, primary care, much better resourcing, needs to play a much more prominent role in the state, and we need to resource those providers to be able to get them on board, Connie, and also able to participate in newer models of care.
Absolutely.
So we have a lot to do and we have a lot to shoot for, but I think Connie is a really critical component of our work moving forward and for the state generally, I think, to improve healthcare performance overall. So I'm looking forward to the next couple of years.
Absolutely. Well, Vicki, this has been an absolutely wonderful conversation. I really appreciate you joining us for this podcast.
It's always great to be with you. And thank
I,
you for all you've been doing to support the work moving forward.
well, thank you.
And in the past.
And in the past. As always, wishing you the best of health. Your host, Tom Agresta.